Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Corcept Therapeutics.
Hello, I'm Dr. Deepak Bhatt, the director of the Mount Sinai Fuster Heart Hospital in New York and the Dr. Valentin Fuster Professor of Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai. Welcome to this program titled A Multidisciplinary Approach to Identifying and Managing Cortisol Dysfunction. Joining me today are Dr. Athena Phyllis Samikas, Corporate Vice President at Scripps Whittier Diabetes Institute and Director of Community Engagement at Scripps Research Translational Institute in California, and Dr. Kristen Mendy, Clinical Professor of Medicine at the University of California, San Diego. Welcome to you both.
Thank you.
Thank you. Glad to be here.
So to get us started, Athena, Kristen, could you tell us about the pathophysiology of cortisol and how this might impact blood glucose or blood pressure? Christian, maybe you could start with blood pressure.
Okay. Well, if you have an elevated cortisol level, it will certainly have a high risk of developing hypertension because cortisol, when it may be overwhelming the 11 beta HSC2, so the enzyme which degrades cortisol, and then the mineralocorticoid receptor gets stimulated by cortisol. And so you would get the identical side effects you would get with aldosteronism. So you retain salt and water. In addition, cortisol by itself actually increases liver angiotensinogen production. So you have the first component of the RAS system upregulated. You also upregulate aldosterone on that pathway. And what is important is that the AT1 receptor, which is the one you block with ARBs, is also sensitized, so it would respond more to catecholamines. It also would respond more to cortisol. So you basically have a sensitization for more potential vasoconstriction. Other aspects are sympathetic tone goes up, your endothelium gets damaged because very often associated endothelial dysfunction. And from a catecholamine or so other hormones, endothelin 1 is elevated with high cortisol. So this pretty much puts it in perspective, but I think mainly the overload of the 11 beta HTS2 making the mineralocorticoid receptor now responding to cortisol. I think that is certainly one of the key features.
Yeah, absolutely. Great point. And anything that you want to say about some data, some new data actually from the Catalyst trial with respect to the prevalence of hypercortisolism, which I would say in the resistant hypertension world has often been thought of as a rather rare thing, but some data from the Catalyst trial that suggests maybe it's not quite as rare as we thought?
Well, I think, it was absolutely surprising. And I think it makes you in a way as a physician say, my God, how many patients have we missed? And not just of the fact that they have cortisol excess, hypercortisol and diabetes, but also now I'm looking at it from a hypertensive standpoint. And if you look at the numbers, if you had difficult to control hypertension, and if you had difficult to control diabetes, you were on 2 drugs or more, you had an incidence of almost 1 out of 4 patients. But if you then look at the subgroup, which was what we would call resistant hypertension with cortisol excess, that group had a 35%. So that's 1 out of 3. So I think for me to look at this clinically new is that anytime you check for cortisolism, you should also check for aldosterone workup, and you should look if you have somebody suspicious of aldosterone excess, you probably should parallel do a cortisol suppression test.
Yeah, no, really great points. it's first of all an enormous universe, of course, of patients that have high blood pressure, and the data are pretty clear now of the effect of both systolic and diastolic blood pressures on cardiovascular outcomes. And within that large universe of patients with blood pressure, there's a cohort of poorly controlled or suboptimally controlled, sometimes called resistant hypertension. The exact definitions depend on which document you look at, but in general, referring to patients who have very difficult to control blood pressure despite, 3 or more different medication classes at maximally tolerated doses. So that's one definition. Certainly, if we're combining resistant hypertension and hard to control diabetes, there does seem to be a much higher prevalence of hypercortisolism as a cause than I think had been commonly appreciated before. But that is the other part of it, the part having to do with glucose and diabetes. And maybe, Athena, I'll turn to you to see what you think in terms of hypercortisolism in this context.
Yeah, sure. So I think this is interesting. And hypercortisolism, from an endocrinologist perspective, we've usually thought about it in Cushing's disease or Cushing's syndrome, where you look for signs and symptoms of excess hypercortisolism, and they're fairly distinct. You're thinking about the classic, the purple striae, the abdominal obesity, the neck, the back of the neck with the buffalo hump. You might have moon faces along with the hypertension that Christian just spoke about. Usually some elevated blood sugars, but that's not necessarily what we most commonly think about. I think what Catalyst showed us and was interesting is that many of these signs and symptoms do not occur. And yet, when we measured the levels of cortisol after a DEX suppression test, we found that they were elevated. So it did, you did have to look at a special population that was fairly glucose resistant and insulin resistant, which is another effect of cortisol from its mechanisms of action. We know it does cause insulin resistance and some elevated gluconeogenesis from the liver, but not to the extent that it would cause this level of diabetes and glucose dysregulation. So that 24% outcome that was found was surprising from our standpoint, and certainly from my standpoint. Other things to look for, just from the pathophysiology standpoint, increased bone turnover, osteoporosis. Again, those are just classic signs of hypercortisolism, but not necessarily always seen in this population that was studied.
Right. And with respect to the Catalyst trial, that was difficult to control diabetes, but I thought that was interesting that in that context, about a quarter of the patients had hypercortisolism. And in those that were on 3 or more than 3 hypertensives, antihypertensives rather, that about 35% had hypercortisolism. So the combination of difficult to control diabetes and difficult to control hypertension really was a double whammy, and the presence of hypercortisolism seemed much higher. Did those results sort of jive what you'd seen in clinical practice to date as an endocrinologist?
I would say not at all. That was part of why it was surprising, mostly because we weren't necessarily looking for it. So again, we're sort of associating. You see the signs and the symptoms that we were classically trained in, and then you go ahead and do the test. We weren't routinely screening a select group of patients, and I think what this study for me did, it was a bit eye-opening in terms of look at your population that has glucose that's not well managed. A1C is above 8% consistently, despite being on multiple medications, some of the best medications that we'll be using now, some of the more innovative and newer, the GLP-1 receptor agonists, the SGLT2 inhibitors, along sometimes with insulin still not managed and controlled well. Maybe take that step further and say maybe we should be checking for hypercortisolism to see if that might be playing a role as well. So maybe just looking at it and thinking about it a little bit differently in the way we screen for this, being cognizant, of course, of you can't screen everybody, because if you screen everybody, then you're going to end up with false positives and go down a path that might not be correct. So thinking about who is the population that you are going to screen as well.
And any comments you have about adrenal imaging? That was done in the Catalyst study as well, but now what the study showed and just your own clinical experience of the value of
Yeah,
adrenal
so
imaging.
that is an important next step. When you did find that post screening it was positive, then we went ahead and we drew ACTH levels so that you could determine if it might be ACTH dependent versus independent. And depending on what those levels showed, then you might go towards a head MRI pituitary screening versus adrenal screening. For those that did look like it would be ACTH independent, we did the adrenal screenings. And again, there, surprisingly found incidentalomas or adenomas that could be surgically removed. Once that happened, it did result in improvements for the patient. So, and then what you're left with is a population thereafter that you need to determine what is the best approach for the ones that don't have an adenoma that might be functional.
Yeah, no, that's terrific and shows some of the thought that needs to go into manage these patients. And we'll come back to it later, but probably really do need a multidisciplinary sort of team, a multi-specialty sort of team in terms of not just identifying these patients, but then the downstream treatments of that. Well, Chris, let me turn back to you. What should we look out for in our patients that would lead us to suspect hypercortisolism in the first place?
Well, I think if you have type 2 diabetes and you have difficulty control, so you go on 2 3 medications and you're still 7.8 or 8 or higher A1C with a compliant patient, and then at the same time you have difficulty to control the blood pressure. I mean, the study clearly showed. I call it the 2+2 to memorize. You take more than 2 medications for diabetes without control, and you take 2 medication without for hypertension without control. I mean, that should be now what we know a red flag to really work up for cortisol excess. And I said at the same time also work up for aldosterone excess. I think because I think there the interconnection is much more common than we have known until now.
Yeah, no, those are good points. And at least some studies have shown that once one has excluded excessive exogenous glucocorticoids, some of the physical exam features and signs that are having the best discriminatory value to have to help diagnose Cushing's are easy bruising and facial plethora and proximal muscle weakness or proximal myopathy and stria, particularly reddish purple and greater than a centimeter wide. Does that sort of coincide with what you've seen clinically?
Yeah, I think this is true, but also from from a nephrology standpoint, we know that the incidence of hypokalemia is relatively low with Cushing, and maybe only about 1 out of 3. But if you have the combination of uncontrolled diabetes, and then you have uncontrolled hypertension, I think that in that setting, talking about the myopathy, you also need to look at electrolyte disorders. They may have as well have hypomagnesemia and hypokalemia. So I think one needs to be aware to look at the electrolyte status and also the renal function status. I think that cortisol alone, if you're healthy and you infuse it or use ACTH, causes hyperfiltration. So your eGFR goes up, but we really don't have very good data what happens after you on cortisone for a month or 2 or 3 with the renal function. Now, the data from Cushing's show that many people with Cushing's, maybe a third or more, develop some renal dysfunction or CKD down the road, but they also have uncontrolled diabetes and they're obese in addition to the hypertension. So I think this is not a clear-cut picture, but if you're insulin resistant, the kidney is really affected by it too, because the podocytes they are dependent on glucose uptake for their production of ATP. So they suffer. You develop podocytes damage and you develop glomerulosclerosis in animals. In humans, we don't have great data, but we know that there is an incidence of increased albuminuria with insulin resistance. So the high insulin levels, which are associated again with hypercortisolism, have negative effects on the kidney from the standpoint of insulin alone and from the standpoint of potentially cortisol alone.
Yeah, no, those are really terrific points. Beyond the potential for Cushing syndrome to cause treatment resistant hypertension or treatment resistant diabetes or both other things, Athena, I think, mentioned unexplained bone loss. And the other thing, too, is treatment resistant depression. So, all things to consider rather holistically when evaluating a patient, not just focusing only on cardiovascular or cardiometabolic issues. Anything there that we missed, Athena?
No, I'm not sure we discussed the details of how we did a DEX suppression test, and classically that has involved a couple different tests, and one of the things we learned is maybe you don't need all the tests, especially if you're going after a population that's a little bit more targeted. We did use the 1 milligram DEX suppression test along with a simultaneous dexamethasone level to ensure that the amount of dexamethasone was adequate to suppress the cortisol levels. And if those were elevated, if the cortisol came back above 1.8 and the dexamethasone was above 140, then that told us that there might be some hypercortisolism. And, traditionally, other tests that have been used include a urinary free cortisol, 24-hour urinary free cortisol, or a late night salivary cortisol, both of which can be either a little bit difficult to collect or may have some inaccuracy. So the simplicity of being able to go down that route with just the 1 milligram dex suppression and then follow up thereafter, I found very valuable. Then, of course, if it comes back elevated, you do go on and do some follow-up tests, including an ACTH level, including then maybe a DHEAS, which is just supportive. And then if you determine you need the adrenal CT, go down that route. So that's sort of your path to how to evaluate this further.
No, that's really useful because I think a lot of people that aren't living in this world might be remembering or trying to remember what they learned in medical school. And, there were a bunch of tests. And I, I suppose for people that didn't go into endocrinology, maybe it was always a little bit confusing. But I think the way you said it really makes the most sense. So the recommendation you would give them is really that the recommended initial screening, if one is suspecting hypercortisolism, is to go with the 1 milligram overnight dexamethasone suppression test, looking the next morning on a blood draw for the values that you mentioned with respect to both cortisol being less than 1.8 micrograms per deciliter and dexamethasone being greater than 140 nanograms per deciliter. Is that a correct summary?
That is, yeah, that is exactly what turned out to really lead you down what those next steps might need to be.
Okay, well, that sounds good. So, I think this is very useful information. Let me just ask, do you feel, I think the answer is yes, but as an endocrinologist, do you feel that the dexamethasone suppression test can be performed in primary care or in other specialties other than endocrinology?
Absolutely, it's the dexamethasone suppression test is pretty simple both to order, and if you're using an EHR, many times it's built in together. If you do dex suppression, it'll build in both the 1 milligram tablet sent to the pharmacy as well as the cortisol, the first morning cortisol level, and they'll label it as a post dex level. The one thing that's maybe not as common is getting the dexamethasone level itself to ensure that that level's okay also, so you might need to add that. But otherwise, fairly simple, and someone might want to consider adding that into an order set or a panel in your EHR.
Sure. And the ACTH, should that be done as a staged test or upfront?
We would usually wait to see if it comes because you're going to get more tests back negative than positive. So we would do that as a second stage test, not right off the bat.
Great. No, that's really practical and very helpful information. So maybe we can just move on now to a bit of a discussion of untreated hypercortisolism. What happens if you don't treat? And maybe, Christian, you can start that off.
Well, I mean, from the standpoint of hypertension, as we just said, it will has really give you a very, very high risk of difficult to treat hypertension. Um, and you said the observational study showed that cortisol excess in the long term is gives you a higher risk of albuminuria and higher risk of developing CKD with a DGFR of less than 60. But these are all observational data, so we really still don't know the exact mechanism because there are so many parallel things. Usually have either diabetes associated, obesity associated, And as I said earlier, you may also have elevated aldosterone levels from the obesity standpoint or from the adenoma in one third of the patients. Or so these aspects of cortisol excess from a kidney standpoint are negative, and especially the cortisol in the kidney causes insulin resistance on the podocyte. And if you have elevated insulin levels, just from hyperinsulinism, it's kind of interesting that insulin in the kidney in a proximal tubule actually is a sodium retaining component. I mean, everybody just thinks that insulin lowers glucose, but it actually increases your sodium. So the more insulin you inject, we know this from the type 2s actually, the more fluid retention there usually is the tendency. So when they come off high dose of insulin, they have usually less edema. So that may be independent of what we just discussed before. So, so I mean, cardiovascular, cortisol causes endothelial dysfunction. If you have cortisol excess, like aldosterone excess, and you have a blood pressure controlled at 140 or 130, you still have more side effects. So when you have elevated cortisol, just get the blood pressure control in a diabetic in the setting we discussed. You still need to reduce the cortisol level. So just controlling the pressure alone still leaves a cardiovascular vulnerability with more atherosclerosis, coronary artery disease, heart failure, stroke, etc., which Deepak, you know very well. So basically, it's not just getting the pressure down. You need to neutralize, so to speak, of the hypercortisolism as well.
No, those are really great points. Have to treat the whole disease, not just one particular manifestation. Athena, anything you wanted to add to those points?
Yeah, I think what we have seen certainly in the recent past with insulin resistance and hyperglycemia in combination with the hypertension, it does lead to more both microvascular and macrovascular disease. So whether it's retinopathy, kidney disease, as Christian just spoke about, or neuropathy, that combination is synergistic and even more detrimental in causing those types of complications. Additionally, some of the recent studies showed that in cortisol-producing adrenal adenomas versus non-functioning adrenal adenomas, there was a higher incidence of not only metabolic syndrome, as you would expect, but also myocardial infarction, strokes, in addition to the diabetes. So it's logical. I think we would expect it, but there are studies also showing that this occurs. So you begin to think that if you can stop this cycle, that it could lead to a reduction in those events as well. Of course, those kinds of larger studies might need to be done, but it does make sense.
Yeah, really great points. Well, thank you both for this very insightful discussion. After hearing all of this, I think we would all agree that these patients would benefit from multidisciplinary care. I alluded to that earlier. For faster diagnosis, for better disease management, that seems like the way to go. But exactly what do you think that would look like? What are your thoughts in terms of how we could actually operationalize this in our healthcare systems?
Maybe I'll take a first stab at that in terms of identification of your patients is probably one of the first steps that if you could do that in a systematic way, might be valuable. If you could screen your EHR for those that have A1Cs that are elevated, maybe hypertension as well, on multiple medications and still not being effectively treated, maybe multiple comorbid conditions as well. And that would be the group to look at and pull out and assess. If they haven't been evaluated maybe for hypercortisolism, then set up a process to do a screening test, not the full evaluation, but just a screening test. So that might be some first steps and approaches.
Yeah, I think those are really actionable points. Christian, what do you think?
Yeah, I think to me, to make it, something to remember is the plus two approach. I think if you are on two drugs for diabetes and you're not controlled, and then you have hypertension, two drugs not controlled, that is probably an excellent initial way to look at it. Also, if you are treating an obese individual who doesn't have diabetes yet, but has very difficult to control hypertension. I think at that point, we probably should also look at cortisol as a component of the difficult to control hypertension. So I think one needs to lower one's threshold that any uncontrolled diabetic with and or uncontrolled hypertension, particularly if they occur together. That's probably, as the study showed, shows it gives you a 1 out of 4 have cortisol excess. I mean, these are millions of people.
Yeah, no, terrific points. I think there are a lot of patients actually like that if we were to follow your 2 by 2 rule. And it's a lot of times in clinical practice, we might assume that, oh, maybe they're not so adherent to their meds or something. But in doing that, maybe we're doing them a disservice because some proportion of them at least may have hypercortisolism or other secondary causes as well. We focused on that. But as you mentioned earlier on, there are other causes as well of hypertension that's difficult to treat, as well as diabetes that's difficult to treat. Well, I certainly hope that this multidisciplinary approach will take off in these specific types of patients. It worked very well, I felt, in advancing diabetes and the series of trials where endocrinologists and cardiologists and nephrologists collaborated to show the benefits of drugs like SGLT2 inhibitors and GLP-1 agonists. Hopefully the same sort of thing can happen and really lead us to evolve this field of not just diagnosing hypercortisolism, but hopefully creating an evidence base to treat it. And, that could really help a good chunk of patients, it sounds like. Any final comments or thoughts, Athena?
I think I might just say that as we started out, I don't think I expected this to have the level of prevalence that was found more recently in a well-conducted study. So I will be thinking about this more often and screening for it more often.
Yeah, I think that's a good message.
It should be added to the workup of anybody who has diabetes and uncontrolled hypertension, particularly if you're on 2 medications each. I think it should become a standard test, which is right now, and it's not. So,
Yeah. I mean, along those lines, is it relatively easy, maybe Athena, you can comment, to get this test? Because at least there's a perception among, I think, some primary care physicians and certainly among, subspecialists like cardiologists, there's just a tough test to get, tough to time it right in terms of both when do you actually do the dexamethasone suppression test, when do you get the follow-up blood work the next morning?
Right, not it. It is not that difficult. You do have to have some standard instructions, of course. Pick up the tablet, take it last thing in the evening, right before you go to sleep. Ideally around 11 o'clock at night, and then go to the lab first thing in the morning. Those are the most important things to remember for the patient perspective and for the ordering. And then thereafter, making sure you obtain both the cortisol level as well as the dexamethasone level.
Yeah. Terrific. A bunch of pearls there. Well, let me leave the audience with a few points that I picked up here. Speaking to these two experts, when there is difficult to treat hypertension, especially when it's coupled with difficult to treat diabetes, think of hypercortisolism. It's a lot more prevalent than most doctors have appreciated based on the most contemporary data. The overnight dexamethasone suppression test is the most sensitive way to diagnose it. And even though there are a lot of tests out there, that's probably the first best test to start with. And finally, multidisciplinary teams are key. If you feel comfortable and are set up to do a dexamethasone suppression test, for example, then great. If you're not and are able to set it up, even better. But if not, and there's a clinical suspicion, I think it's still okay to refer to someone who'll do that type of testing. Whether in the case of our discussion today, it was an endocrinologist or whoever might deal with difficult to treat diabetes or hypertension. That can vary from place to place. Some places that's an endocrinologist, other places, especially with respect to hypertension, it could be a nephrologist. In some places, it's a cardiologist or a preventive cardiologist. So a lot of different specialties potentially touch upon these patients. But I think the key is to have really multidisciplinary teams so that these patients, when they're getting identified, can get the appropriate workup and therapy for that matter. Well, Athena, Christian, thank you for a great discussion. I found it really educational. I hope the audience did too.
well, thank you. That was a pleasure to participate.
Same here. Thank you, Deepak.
And thank you to the audience for participating in this activity as well. Hopefully, this is something that will inform your daily clinical practice. Please do continue on to answer the questions that follow and complete the evaluation. Thank you again so much for joining.